Hi everyone. Hello.
Good evening, ma'am.
Good evening. Good evening.
Please start. Please start.
Good evening, everyone. I am Dr. Jyoti Dahiya, your screen coordinator for today's ISA National PG online class. On behalf of ISA, I warmly welcome all the faculty members, residents, and participants. These academic sessions are conducted every Monday and are also available online on the ISA NHQ YouTube channel, along with live streaming for wider access. Let us begin today's academic session on an auspicious note with Saraswati Vandana. Now, I would like to invite our Honorable Secretary, Dr. Rajiv Gupta, to kindly address the gathering and share a few words.
Come. See, this is 1 minute.
Good evening, everyone. Welcome to this ISA online PG class, which is very important, where we will cover two topics. One is neuromuscular monitoring and another is perioperative management of case of intestinal obstruction in an adult. So we know neuromuscular monitoring is very important, particularly in the cases of general anesthesia. And the purpose of this is to assess the depth of neuromuscular blockade and guiding so that you can be guided for the dose of muscle relaxants and to adequate reversal is ensured. So we will discuss what are the methods, what is peripheral nerve stimulator, how the things are done, what is TOF, what is tetanic stimulation or double burst. So many things we will be discussing here along with the perioperative management of intestinal obstruction. So over to you for starting this class.
Thank you so much, sir. I now hand over the proceedings to my co-screen coordinator, Dr. Nusrat Anjum, to take the session forward.
Thank you, Dr. Jyoti. A very good evening to everyone.
Good evening, ma'am.
It is my this is Dr. Nusrat Anjum. I am currently working as assistant professor in the Department of Anesthesia in Gulbarga Institute of Medical Sciences, Kalburgi. It is my privilege to introduce our esteemed speakers for today. Firstly, I would like to introduce Dr. Jaya Prabhakar Dige. Ma'am is a professor and head of Department of Anesthesiology at Shri Bhau Saheb Hire Government Medical College, Dhule, with over 33 years of teaching experiences. Her areas of special interest include epidural anesthesia. She has made a significant contributions to academics, professional bodies. She has even served as IMA secretary in 2010, IMA president in 2015, and also as ISA president, along with being an executive council member of ISA for 2 years. She has been very actively involved in organizing multiple CMEs and immensely contributed to the developmental of department. She's also a recipient of COVID Work of Excellence Award. Academically, she has 5 national, 2 international publications to her credit. We are truly honored to have you with us today, ma'am. I warmly welcome you for this session.
Thank you.
Secondly, I would also like to welcome our second faculty for today's session, Dr. Sandeep J. Patel. Sir is an associate professor in Department of Anesthesia at SBI GMC, Dhule, Maharashtra, with more than 15 years of rich teaching experiences in both undergraduate and postgraduate teaching. He has several academic contributions, including around 10 national and international publications. He has also served as Dhule ISA Treasurer for 5 years from 2012. We are truly honored to have you with us today, sir. I warmly welcome you, both of you.
Thank you very much.
Before going further, I would like to enumerate few rules for today's session. The firstly, audience will be muted throughout the session. The audience is requested to keep their videos off during the session. You can put up your queries in the chat box, which will be addressed at the end of the session by the PGs and the faculties. Now I request the faculties to please introduce the postgraduates of today's session. Thank you. Over to you, sir. Over to you, ma'am.
Thank you. Good evening and welcome everyone on this platform. I really thanks Dr. Raju Gupta sir, Honorary Secretary, ISA National, Dr. Bajwa sir and Dr. Madhuri Kurdi sir. Really, I'm thankful because they are giving me the opportunity to represent my city as ISA Dhule City Branch and GMC Dhule. And I'm protecting now. I am about these 2 lectures. So now 2 students of from my JR3 residents, I'm projecting them for this lecture. One is Dr. Neha Kumari. She's highlighting the topic on this neuromuscular blocking. And second topic is Dr. Sheetal. She's presenting the intestinal obstruction in management in the adults. So now we can start the lecture. Now I will request Dr. Neha Kumari to start the lecture.
Good evening, respected National ISA faculty member, all the respected seniors and my colleagues. Myself, Dr. Neha, junior resident at SPH GMC College, Dhule. So today, my topic is neuromuscular monitoring. Now I will be sharing slides.
Is there any problem with sharing the slides, Dr. Neha?
Is it visible, ma'am? Slides?
No.
Okay. Now is it visible, ma'am?
No. Yeah,
Now
it
it
is
is
seen,
visible.
but
Now it is
make it
visible.
white. Make it white. No, it is not seen. You do one thing. In case you have a problem, Dr. Sheetal can share the slides and you can read them. Or Dr. Sheetal can present first in case there is a problem with you, Dr. Neha.
Ma'am, I will try once more.
Yeah. If it doesn't come, means let Dr. Sheetal present the obstruction case. Then you can present the neuromuscular monitoring.
Yes, ma'am.
Dr. Sheetal, you be ready.
Yes, ma'am.
शीतल शेयर कर मैं देखती हूँ. Ma'am, can Sheetal share first?
Yes, yes.
Because it's
Good evening, ma'am. I will be sharing the slides.
Introduce yourself.
Yes, ma'am. Are my slides visible, ma'am?
Yes.
Good evening, everyone. Good evening, ISA national faculty members, other faculty members, seniors, and my colleagues. Today, I will be presenting a short topic on anesthesia for acute intestinal obstruction. I am Dr. Sheetal Dhaigode, Junior Resident Anesthesia Department, Hire Medical College, Dhude. I will be presenting this under guidance of Dr. Jayadigi ma'am and Sandeep Patel sir. There is a 73-year-old woman with an acute abdomen was scheduled to undergo an emergency exploratory laparotomy. She complained of severe abdominal pain with periodic bouts of bilious vomiting. Her past surgical history included a right hemicolectomy for colon cancer. She had a blood pressure of 110/70 mmHg and pulse rate of 88 beats per minute. By asking history and by these things, we come to suspicion of conclusion that she might be having intestinal obstruction. So what is intestinal obstruction? It is a mechanical or functional blockage arising from a structural abnormality that presents a physical barrier to the progression of gut contents. It is divided into following types: partial or complete, simple or strangulated, acute or chronic, dynamic or adynamic. On the basis of origin, it is divided into following: extraluminal, which for example adhesions, hernias, carcinomatosis; intraluminal cause, for example gallstones or foreign bodies; intramural cause, for example Crohn's disease or tumors. What is dynamic obstruction? In it, peristalsis is working against a mechanical obstruction. In a dynamic obstruction, there is atony of intestine, loss of normal peristalsis, and mechanical obstruction is not there. Most common cause of small bowel obstruction is post-operative adhesions. That's why in our history, we have asked patient of having any surgical intervention. And large bowel obstruction, most common cause is neoplasms. Small bowel obstruction is more common in 60 to 80% cases than large bowel obstruction. And large bowel obstruction is more insidious finding, and systemic derangements are more with large bowel obstruction. What will be the preoperative management in this patient? We have to manage fluid and electrolyte imbalance, bowel and abdominal distension, respiratory cardiovascular problems. Patient will have complaints of vomiting, regurgitation. We have to deal with aspiration risk, investigate the patient, optimize and post for OT. In fluid and electrolyte imbalance, there will be dehydration. Normally, 7 to 9 liter of fluid is secreted into upper intestinal tract daily, but of it, more than 6 to 8 liter fluid is absorbed daily. But because of intestinal reabsorption, and because of intestinal reabsorption, only 400 ml passes ileocecal valve. But in intestinal obstruction, there is fluid loss because of increased secretion, decreased absorption, which leads to accumulation of fluids. As intraluminal pressure increases, the secretory function of bowel increases. When pressure rises above 20 centimeters of water, reabsorption is impaired. This causes loss of isotonic salt water, resulting in isotonic contraction of extracellular fluid volume, which causes dehydration, and there is increased hematocrit. So here will be my question. The most important preoperative concern in intestinal obstruction is there are four options. First is pain control. Second is fluid and electrolyte imbalance. Third is antibiotic administration. And fourth is early mobilization. So the answer for this question will be fluid and electrolyte imbalance. We have to deal with it thoroughly. When 1500 ml of fluid accumulates at early stage, patient won't be having much complaints. When 3 liter of fluid accumulates in bowel, patient will start complaining of vomiting. And when the fluid accumulation increases to 6 liter, at later stages, patient will present with tachycardia and hypotension. The degree of dehydration is evaluated by following things. First is duration of illness. Second is presence of vomiting or not. Third is skin elasticity. Fourth is sunken eyes. And fifth is oliguria. The degree of extracellular fluid loss can be monitored by serial hematocrit determination. There is rise in hematocrit proportional to the amount of fluid loss. If hematocrit increases to 55%, this indicates that about 40% of plasma and extracellular fluid volume have been lost. Treatment for this, while treating this, our primary goal is initial restoration of intravascular volume to the state of normovolemia, correction of electrolyte disturbances, and acid-base derangements. Lactated ringer solution is appropriate to use for resuscitation. We can give fluid replacement by guiding central venous pressure, hourly urine output, blood pressure, heart rate, and skin turgor of the patient. What is the most common electrolyte abnormality in a patient with intestinal obstruction with complaints of multiple episodes of vomiting? When patient is having multiple episodes of vomiting, what he will be having? Hyperkalemia or hypokalemic alkalosis. Third option is hypernatremia, or fourth option is acidosis. So the answer to this question is hypokalemic alkalosis because of potassium losses and acid losses in the vomiting. What will be the electrolyte disturbances in this patient? Hyponatremia and hypochloremia because of fluid accumulation and vomiting. Hypokalemia will be there when the sepsis occurs and when renal failure occurs, mainly due to renal mechanism, and secondary to metabolic alkalosis and hyperaldosteronism. What is hypo and hyperkalemia? The normal potassium level is 3.5 to 5 milliequivalent per liter. Hypokalemia occurs when it decreases to 3.5, and hyperkalemia occurs when it increases to 5 milliequivalent per liter. Common causes of hypokalemia are gastrointestinal losses like vomiting, diarrhea, renal losses like diuretics, hyperaldosteronism, insulin therapy. Insulin causes intracellular shift of potassium, which in turn causes to hypokalemia, beta agonist, and metabolic alkalosis. Hyperkalemia causes are renal failure, hypoaldosteronism, potassium sparing diuretics, angiotensin converting enzyme inhibitors, ARBs, tissue breakdown like rhabdomyolysis, hemolysis, or metabolic acidosis. Neuromuscular symptoms will be there. In hypokalemia, there will be muscle weakness, cramps, paralysis, and hyporeflexia. And in hyperkalemia also, muscle weakness will be there, paralysis, paresthesia, or reflexia will be there. What will be the cardiac effects in hypokalemia? Arrhythmias, atrial and ventricular tachyarrhythmias will be there. And in hyperkalemia, life-threatening arrhythmias, a fibrillation, a systole will be there. ECG changes in hypokalemia are flattened or inverted T waves, ST depression, prominent U waves, and prolonged QT interval. In hyperkalemia, there will be tall T waves, wide QRS complex, prolonged PR interval, sine wave, which is a classic pattern seen in severe cases. Gastrointestinal symptoms. In hypokalemia, there will be ileus and constipation, and in hyperkalemia, nausea, vomiting, and diarrhea will be there. Acid-base association. Often, hypokalemia often associated with metabolic alkalosis and hyperkalemia with metabolic acidosis. What will be the treatment for this? We will treat hypokalemia by oral or IV potassium replacement, correct underlying cause. And for hyperkalemia, we will first, if ECG changes are there, we will stabilize the heart by giving IV calcium gluconate, followed by insulin plus glucose drip, beta agonist, sodium bicarbonate, potassium binders, and in severe cases, dialysis. Clinical manifestation of sodium imbalance, there can be hyponatremia or hypernatremia. Normal sodium levels are 130 to 145 milliequivalents per liter. Hyponatremia occurs when sodium decreases to 135 and hyper occurs when sodium count increases to 145 milliequivalent per liter. What will be the symptoms in hyponatremia? There will be nausea, vomiting, diarrhea, abdominal cramps, tachycardia, hypotension, headaches, apprehension, lethargy, confusion, depression, seizures, muscle weakness will be there. Dry skin, pale dry mucous membrane will be there. In hypernatremia, there will also be nausea, vomiting, anorexia, rough and dry tongue, tachycardia, possible hypertension, restlessness, agitation, stupor, elevated body temperature, muscular twitching and tremor and hyperreflexia will be there. And skin will be dry and dry sticky membranes will be there. So how do we treat hypo and hyperkalemia? For hyponatremia, administer IV sodium chloride and diuretics if hypervolemia is there. Limit water intake and teach about foods that contain salt. For treating hypernatremia, if it is due to fluid loss, administer IV fluids. If due to inadequate renal excretion, give diuretics that increase sodium loss, restrict sodium and fluid intake. What will be the acid-base imbalances in patient presented with intestinal obstruction? Long-standing intestinal obstruction patient will have metabolic acidosis, which is due to dehydration and loss of alkaline intestinal secretion and due to starvation ketosis. Bowel and abdominal distension will also be there due to accumulation of fluids and gases, which results in blockage of venous outflow, blockage of the blood supply to the obstructed segment, hindering of diaphragmatic movement, which increase intra-abdominal pressure, decreases venous return and in turn cardiac output. Progressive distension may cause rupture of colon. Progressive distension may cause tense abdominal wall. How do we manage abdominal distension? By putting nasogastric tube for abdominal decompression in perioperative period only. And we maintain deeper planes of anesthesia and give muscle relaxant intraoperatively to provide adequate operative conditions. Intraoperatively, there will be gradual escape of fluid. So we have to monitor BP frequently during incision and intraoperatively because sudden escape of fluids into the peritoneal cavity may cause severe hypotension. What is the role of nasogastric aspiration? It reduces bowel distension. Secondly, it improves pulmonary ventilation by relieving distension. It reduces risk of subsequent aspiration during induction of anesthesia and post-extubation. What will be the respiratory problems? Since we already know that the patient has patient complaints of abdominal distension, which hinders the diaphragm, resulting in inadequate ventilation. This decreases tidal volume and functional residual capacity and causes a decrease in PaO2 and increase in PaCO2. There will be weakness of intercostal muscles due to hypokalemia. There will be hypotension and tachycardia also due to first reason is hypovolemia, and because of decreased venous return, cardiac output will be decreased because of septic shock and hyponatremia. Patient will also complain of vomiting and regurgitation, and that's why we will face the risk of aspiration during induction and extubation. Because aspiration is there because while reversal of peristalsis occurs and mechanical obstruction pushes intestinal juice in addition to gastric juice to produce a full stomach with an increased intra-abdominal pressure. What will be the major investigation, specific investigation we will be doing in this patient? It is X-ray abdomen in supine and erect position to ensure diagnosis of intestinal obstruction. Which finding is typical on X-ray abdomen in small bowel obstruction? There are four options. First is coffee bean sign. Second is dilated loops with air fluid level. Third is apple core lesion. And fourth is pneumoperitoneum. In small bowel obstruction, there will be dilated loops with air fluid level will be there. In small bowel obstruction, multiple loops will be there, and in large bowel obstruction, few loops will be there. We can differentiate it on the basis of X-ray. And to detect complication and further investigate the patient, we will advise the patient to do HB, WBC, platelet count, electrolytes, LFT, RFT to know the basic values, and arterial blood gas for knowing acid-base disturbances. We will thoroughly investigate the patient, optimize the patient, and take patient inside OT. We will ask the surgeon to keep the patient kneel per oral and avoid all oral pre-medication. In inside OT, titrated doses of opioids and sedatives can be given. In pre-medication, metoclopramide should be avoided, which is commonly given to patients which are considered high risk for aspiration, because in this case, metoclopramide is a prokinetic drug and increases the peristalsis of the intestine, and which will worsen the obstruction. So metoclopramide is avoided. Titrated doses of anticholinergics can be given. It is said that because antacids and H2 blockers, they decrease the risk of aspiration, but they may stimulate vomiting, and they are of low value if a large volume of fluid are already sequestered in the bowel, example in high intestinal obstruction. So tablet forms of this which are given in the ward should be avoided in such patients. For intra and post-op analgesia, we can take consideration of epidural catheterization if the hydration status of the patient is adequate, if total leukocyte count is within acceptable limits, and no metastasis is detected in vertebral region. For intraoperative management, we have following modalities. We will choose the anesthesia, choice of anesthesia, monitoring, induction and intubation, maintenance, and extubation of patient. The most appropriate induction technique in patient with intestinal obstruction is four options. First is inhalational induction, second is slow IV induction, third is rapid sequence induction, and fourth is sedation only. So the answer is rapid sequence induction, because in such patients there is high risk of aspiration, and to minimize this, we will induce the patient by rapid sequence induction. The choice of anesthesia regional is usually avoided, because in most of the patient fluid depletion will be there, or intraoperatively because of fluid shifts there can be chances of hypotension. So general anesthesia is the method of choice. For monitoring, I will attach ASS standard monitors like pulse rate, BP, SpO2, temperature. Along with it, central venous pressure monitoring can be done to guide fluid therapy. For rapid sequence induction, it is done in supine position with head down tilt to avoid aspiration if vomiting occurs. Emphasis is given on pre-oxygenation with 8 to 10 liter of 100% oxygen for 2 to 5 minutes. Nasogastric, there are two thoughts. Some say that nasogastric tube should be removed before intubation, because to allow the effective cricoid pressure, avoid lower esophageal sphincter dysfunction, and to avoid hindering of laryngoscopy and intubation. But there is second thought also, that if we do RT aspiration properly and patient is not having vomiting currently, then nasogastric tube can be put in situ and we can proceed with the induction. For IV induction, if patient is hemodynamically stable, we can go with propofol or thiopentone. If there is hypotension, ketamine or etomidate are good choice. Why nitrous oxide should be avoided intraoperatively in a patient of intestinal obstruction? Because of hypotension, because it expands bowel gases, because it causes hypoxia, or because it lowers depth. So the answer is it expands bowel gases. Already because of obstruction, there is abdominal distension, bowel distension is there, and with N2 we are we are worsening it. So that's why N2 is avoided. For maintenance, O2, potent oxygen, potent inhalational agent, non-depolarizing muscle relaxant, and intermittent positive pressure ventilation can be given. Careful titration of doses of inhalational agents can be done to avoid hypotension and
Is there a problem? Dr. Sheetal, you are not heard. Dr. Sheetal, you are not heard. Screen coordinators, just check. Dr. Sheetal?
You have
Hello,
to
Sheetal.
unmute yourself.
Good evening, ma'am. Am I audible, ma'am?
Yes, we have missed last 3 to 4 minutes of your talk. You were muted. Can you repeat?
Yes, ma'am. Yes, ma'am.
Sheetal, go ahead.
Is there any problem, Dr. Sheetal? I
Hello,
think
Sheetal.
she's
Is at our medical college there is always the range problem, always. Sheetal, are you there?
the problem is she's muting herself. That is the problem there.
Ma'am, it is occurring
Yes.
randomly, ma'am. I don't know how.
Okay, that is okay, no problem. Go ahead. You're clearly heard now. Please go ahead. Dr. Sheetal, just let us know what is the problem. We are waiting for you.
Dr. Madhuri, is this a problem?
No, they are having some problems, these Dr. Sheetal, and there is no problem from our side.
Okay, okay.
Dr. Sandeep,
Yes, madam.
sir, in case she has a problem, you can share the slides, sir.
Okay, madam. I will.
We have to continue the class. Let anybody else share the slides, but please continue. If you want us to share, we will also share, no issues.
Yes, ma'am.
You please take her slides, sir, and you can continue with it.
Ma'am, there are two questions. Can we take the question?
Yeah, till that time we'll take the questions. Yes.
Dr. Lalit wants to ask if NG tube hinder laryngoscopy or intubation.
Actually, there are two school of thoughts. NG tube is very important because we have to do proper RT aspiration prior to induction, because it will reduce the gastric content. Because in Mendelssohn syndrome, there are two things which are very important. One is the volume of gastric content, and another is the pH of gastric content. So by NG tube, we aspirate the contents and reduce the volume. So if proper RT aspiration is done, then no necessity to remove the NG tube. Another school of thought is we can remove the NG tube before induction, after aspiration done. Aspiration of the gastric contents done.
But in the lecture, it is mentioned that it hindered the laryngoscopy and intubation. My opinion is it never.
Yes, sir. It never.
The slide has mentioned it hinder. It never hinder.
Yes, sir. It never hinders.
That's why I have objected that. Okay.
There's another question from Dr. Maria. In case of hyperkalemia, if rocuronium is not available, how should be the intubation done?
Actually, in intestinal sequence induction is to be done. If rocuronium is not available, now agent available for us is the scoline, and we can avoid the hyperkalemia which is induced by the scoline. So we can give pre-colorization prior to giving the scoline. Or another option is we can do priming using the 1/5 dose of atracurium followed by induction and remaining dose of the atracurium, that is priming. So the duration of intubation will be reduced from 180 seconds to 60 to 90 seconds.
Okay, thank you, sir. I think Dr. Sheetal has come, so we can resume the class now.
Yes, ma'am.
Sheetal, go ahead. शीतल का पूरा ही हो गया.
Madam,
Is
if
it
Dr.
visible,
Sheetal is
ma'am?
having a problem, we are falling short of time. So let her slides be shared by somebody else. Because I don't think she will be able to share now. It's already a lot of time is done. Let her slides be shared by somebody else. Any other questions?
Yes, ma'am, there is another question. Dr. Konda Reddy, he wants to ask, what is self-taming technique? Sandeep sir, would you like to answer?
Pardon, ma'am, what is self?
What is self-taming technique?
Self-taming.
Hello, ma'am. Self-taming means the same dose is being given before the whole dose of this choline, choline. Am I audible?
Yes, ma'am, you're
Yes,
audible.
ma'am, you're very much audible. So, as the name suggests, and as Dr. Konda Reddy has already mentioned the term self-taming, so I don't know whether he has heard of the term somewhere, but it is, as Jaya Madam said, a small amount of the drug itself is given before the full intubating dose. That is why it is known as self-taming, and especially it is given during a rapid sequence induction. Okay, so it helps to reduce the incidence of and the intensity of the muscle fasciculations with come with choline. So
Yes,
around 0.1, a very small dose like 0.1 milligram per kg is injected. Okay?
yes,
Yeah.
ma'am.
So screen coordinator, Dr. Jyoti,
Yes,
you will
ma'am.
have to share the PPT of these PGs. They have a
Yes, ma'am.
problem there. Okay. Meanwhile, Dr. Mridula Vatve, madam, had just raised her hand. Madam, do you want to give some input? We have around 130 participants today. The forum is full.
Am I audible, Madhuri madam?
Yes, very much, ma'am. Please.
Regarding RT aspiration and all, my opinion is we are not supposed to remove the nasogastric tube. It should be fixed properly at the nasal border, but it should not come in the way of laryngoscopy. And an assistant should be always there to take care of that RT, which is the whole motto is to prevent aspiration. And it will hinder sometimes, but we should not remove it. Somebody should fix it properly, and the critical pressure should be given during the time of induction.
But
What we used to do
Yes,
previously.
yes. Fully agree with you, ma'am.
Yeah, it hinders, but still, then it should be aim should be achieved. Uh, that's the thing. When we are using pentothal also, and now propofol or ketamine also. That much I wanted to add. So
Yes, yes, yes. Fully agree with you, ma'am.
yeah.
And I don't know, but there was some discussion here sometime back with Dr. Lalit Rage sir saying that it does not hinder the view of the hinder the view during laryngoscopy. So I would like Dr. Lalit Rage sir to explain this. That is, if sir is online. Sir, are you online? Madam, we cannot take neuromuscular monitoring. We want the intestinal obstruction to continue.
Yes, good.
Please. Please continue with the intestinal obstruction.
Ma'am, there's another question on the same line.
Okay.
Samsung is
You
asking
please
why.
keep ready the intestinal obstruction slides. We are just discussing, but you please keep the intestinal obstruction ready. I will manage the questions. Okay. Yeah.
Ma'am, question is while using IGL in routine cases, is it advisable to always use the NG tube?
What is that? Removing
Ma'am, while
a
using the
suction
IGL
necessary?
in routine cases.
No, can you repeat? Show me the question again.
Ma'am, this is by Samsung. While using IGL in routine cases, is it advisable to always use the NG tube?
No, but the question of supraglottic device in intestinal obstruction doesn't arise at all. One cannot dream of doing an intestinal obstruction case with a supraglottic device.
Yes, ma'am.
Whether it is for second generation or whatever, no. It's a big no.
Yes,
Are
ma'am.
you ready with the slides of intestinal obstruction? Please start. We're waiting for you. Who is displaying the slides?
Good evening, ma'am. Ma'am, I was playing slides of neuromuscular model. Should I
No,
start
you
sharing,
cannot.
ma'am?
You cannot. You
Okay.
have to complete the intestinal obstruction.
Yes, ma'am. Sorry.
Yes. Till that time, we are discussing the topic.
Ma'am, Dr. Maria wants to ask if we are priming or pre-colorizing before schooling, how fast we can intubate the patient instead of 1 minute.
With priming, we can intubate within 90 seconds. If you are using ATRA followed by atracurium, then up to 90 seconds we can intubate. The time duration is reduced from 180 seconds to 90 seconds. Am I audible?
Yes, sir. Thank you, sir.
Okay.
Are the slides ready? Intestinal obstruction.
Ma'am, we are not able to reach her.
We cannot stop the topic like that in between and go to another topic. You ask her to put it, send, no?
Ma'am, Dr. Neha Kumari has shared.
Okay. What has she shared?
Ma'am, her PPT she has shared.
No, we cannot go. We have to finish intestinal obstruction first. You cannot just jump from one topic to the other. We will wait till they are able to show the slides.
There is another question from Dr. Prashant. What is Selix maneuver and how it is done?
Selix maneuver is nothing but giving cricoid pressure during the rapid sequence induction. Once the patient induction is started and patient becomes unconscious, the cricoid pressure is given to obliterate the esophageal lumen up to 30 Newton or 3 kg. And once the laryngoscopy is done, intubation is done, and cuff is inflated, then and then only the pressure is relieved.
Thank you, sir. There is another question. Can we use glycopyrrolate as it decreases the lower esophageal sphincter tone?
Yes, you can use only the patient is having fever or tachycardia. Then and then we avoid it since the patient is already having a Ryle's tube. So there is no role of that lower esophageal sphincter. Means glycopyrrolate will interfere that because already the Ryle's tube is there. So we can use glycopyrrolate only if fever or tachycardia is we can avoid the anticholinergics.
Thank you, sir. Sir, is there any chances of regurgitation with glycopyrrolate?
Yeah, it reduces the lower esophageal sphincter pressure. So it is given that there are
Jyoti? Dr. Jyoti? Dr. Jyoti?
Yes, ma'am.
I think they have some serious problem. We will shift on to neuromuscular monitoring.
Okay, ma'am. I will share the
I
slides.
hope there is no problem there also. Yeah.
Madhuri, one sec. I think she has shared to Sandeep. Sandeep, sir. Sandeep, sir. Am I audible, Sandeep?
Yes, ma'am.
So she has shared to you, I think, PPT. Is it with you?
No, madam.
Okay, so Nanya, you continue.
Yes, ma'am. Should I start, ma'am?
Yes, yes.
Okay, so this is my topic. So this is the neuromuscular monitoring under the guidance of respected Dr. Jayadege ma'am. I'm Dr. Sandeep Patel, sir.
Kindly mute yourselves, all of you. Please mute yourselves.
Neha, you continue.
Yes, ma'am. Ma'am, next slide, please.
नेहा तो म्यूट कर दिया तूने.
Ma'am, next slide, please. Okay, so the neuromuscular monitoring we are doing, these are the certain indications to do the neuromuscular monitoring. So the first indication is if after the prolonged infusion of the neuromuscular blocking drugs or when long-acting drugs are used. So we have to do the neuromuscular monitoring if there is a prolonged surgery or the prolonged anesthesia has been given to the patient. That is the second indication. The third indications we do neuromuscular monitoring so that the patient can have the adequate reversal before extubating, because in some conditions, like if the patient is morbidly obese or if there is a respiratory disease, and if we extubated the patient without complete recovery, that can have the devastating effect on patient. So for this also we have to use the neuromuscular monitoring. The fourth indication is it can be administered where the administration of the reversal agent, which is my newest regimen, can cause the harm. For example, it can lead to the tachyarrhythmias or the cardiac failure if it is given before the adequate reversal of the patient. The fifth indication is in the patients with a liver or renal dysfunction. Why? Because we know when the pharmacokinetics of the muscular relaxant may be altered, because most of our drugs, whether it is a depolarizing muscle relaxant or whether it is a basically the non-depolarizing muscle relaxant, their metabolism and excretion happens to liver or renal. So liver, or if there is a liver failure or there is a renal dysfunction, so there can be the prolongation of the muscle relaxant. So for that we have to do the monitoring. The sixth indication is the neuromuscular disorder. So for example, in the patient with a myasthenia gravis or the Lambert-Eaton syndrome, so myasthenia gravis is a disorder in which there is antibody which is present against the acetylcholine receptor, which is present post-synaptically. So both depolarizing muscle relaxant and the non-depolarizing muscle relaxant can have the different effect on these disease. So we have to do the neuromuscular monitoring for these disorders also. Then the seventh indications for doing neuromuscular monitoring is the surgeries which is requiring the profound neuromuscular blockade. So those surgery, for example, the neurosurgeries, or if there is any vascular surgeries, especially the eye surgeries, when we want to do the retinal procedure or the vitreous surgeries, in that condition, so these are the procedure which will be requiring the intense neuromuscular blockade. So that we have to monitor the neuromuscular monitoring should be done. So these are my 7 indications to do the monitoring. Then there is a principle for the neuromuscular monitoring. So the nerves will follow the all or none pattern. So basically the reaction of a single muscle fiber to a stimulus follow an all or none pattern. In contrast, the response, that is the force of contraction of whole of the muscle, depend on the number of the muscle fibers activation. So what if the nerve is stimulated with the sufficient intensity? So if you have stimulated a nerve with a good intensity, so all the fibers of the nerve will react and there will be the maximum response which will be generated, and this is going to follow all or none rule. So after the administration of a neuromuscular blocking drugs, the response of the muscle decreases in parallel with the number of the fibers blocked. So more fibers, if it has been blocked with my blocking drugs, there will be more muscle relaxation. The reduction in the response during constant stimulation reflect the degree of neuromuscular block. So difference in the type of the blockade produced, whether by the depolarizing or the non-depolarizing relaxant, account for their different response to the nerve stimulation. So this is the principle. All the muscle fibers and the nerves is going to follow the all or none rule. So we have the different neuromuscular monitors. We have the two type of the monitoring we will be doing. So first is by the nerve stimulator, which is my peripheral nerve stimulator. So what is the ideal qualities of these nerve stimulators? So these are the 5 qualities. So first is the current. So we can give a current up to 80 milliampere. The duration of each stimuli should be 0.2 to 0.3 milliseconds, and there should be the constant current over the wide skin resistance. And fourth is these monitors should display the current level. They should display the polarity of the electrodes. And when we use the peripheral nerve stimulator, we are going to get to the stimulation pattern. So in total, the 5 stimulation pattern we are going to get. So first is the single twitch. The second is the train of 4 ratio. The third is the post tetany count. The fourth is the double burst stimulation, and there is a technique stimulation which is also getting, that is the 5th one. So we are getting with the peripheral nerve stimulator. The second type of monitoring can be done, which is called as the evoked response sensor. So total we have 5. First is we can do the mechanomyography. So what is this mechanomyography? So these are the evoked mechanical response of the muscle. So the mechanical response which will be generated by the muscles when we provide an electrical current, that can be measured with the help of a mechanomyography. The second type of the response is the evoked electrical response. So when we give the signal, the muscle is going to have some electrical activities which will be recorded by the electromyography. And the third is the acceleration of the muscle response, which is called as the acceleromiography. The fourth response we are getting is the evoked electrical response in the piezoelectric film sensor, which is attached to the muscle, that is called as the kinemyography. And the fifth is the measurement of the low frequency sound. So these are the low frequency sound which will be evoked by the muscle contraction, and this is called as the phonomyography. These 5 things I have explained in next slide. So first is the mechanomyography. So what is this mechanomyography? So mechanomyography is measuring of the force of contraction of a thumb against a fixed preload tension. So we provide a force of contraction. This force displacement, so this force displaces my transducer, which is converting this mechanical energy into the electrical signal. And this is the gold standard. But the problem with this mechanomyography is it is very cumbersome. So mainly it is going to use for the research purpose. We cannot do it in the OT. The second thing is the electromyography. So again, same. So it records the compound action potential, which is produced by the stimulation of the peripheral nerve. So we are stimulating the peripheral nerve and we are getting the response. So direct muscle stimulation is quite possible. These are highly sensitive to the electrical interference. So this is the second monitoring, which is the electromyography. The third monitoring is the acceleromyography, which is based on the Newton's second law. So it states force is equivalent to the mass into acceleration. So in the acceleromyography, we have the piezoelectrical ceramic wafer electrode, which is going to convert the acceleration of the thumb movement into an electrical signal. So the AMG, this acceleromyography measurements are higher as compared, so it is better as compared to the mechanomyography and the electromyography. Okay, so what is this neuromuscular monitoring? So first thing we should know is the threshold current. So what is threshold current? So it is the lowest current which is required to stimulate all the fibers of a nerve bundle and produces a detectable muscular response, which is called the threshold current. And what is the supramaximal stimulus? So this is 15 to 20% greater than that is required for the threshold current. So whatever threshold current I am getting, 15 to 20% higher than that is my supramaximal stimulus. The thing with this supramaximal stimulus is it in the awake patient. So we have to calculate the supramaximal stimulus by knowing the threshold current. So this is my peripheral nerve stimulator. different marking. So this is a TOF, which is a train of flow ratio. It is showing. Then in the right corner there is Hertz, which is the frequency which we are going to use. This is MA, which is milliampere. So it will show the current. Percentage. It will show the percentage of the train of flow. Then in down of this peripheral nerve stimulator, we have different frequencies. For example, we can press a train of flow. It will give the train of flow ratio. We can do the PTC. That is the post technique count we can do, and this is 1 Hertz. That is the a single twitch frequency which are going to give. This is milliampere. So the button for increasing or decreasing the current which we are going to use for the nerve stimulation. So this is my peripheral nerve stimulator. Okay, so this is the peripheral nerve stimulator which we are going to use, and how we are going to place the electrodes. So for the neuromuscular monitoring, we have to place the electrodes. So what is these electrodes that we are putting on the hand? These are the disposable pre-gelled silver or the silver chloride surface electrode, which is commonly used. So these electrodes are basically made up of the silver chloride, and it has a conducting area of 7 to 11 millimeter in the diameter. So usually the electrodes are placed on the skin, but suppose if you are using the needle electrodes, it should be placed subcutaneously to avoid the nerve injury. And before placing the electrode, we have to clean the area with antiseptic. So skin should be properly cleansed, and it should be scrubbed before the electrode application. So that area we have to cleanse properly. Then we have to place the electrodes. So these are the sites of the nerve stimulations. So we use different sites for the nerve stimulation. So the first, it can be, so most commonly which is used is the ulnar nerve. The other nerve which can be used is the median nerve. The third nerve which can be used is the posterior tibial nerve. And the fourth nerve is the common peroneal nerve. And fifth is the facial nerve. So these are the site where we are going to stimulate my nerve. And before that, we have to cleanse that area properly. Then this is how we are going to place. So we are going to place 2 electrodes on the volar surface of the hand. So this is my volar surface, and we have 2 electrodes. One is anode and one is cathode. So this is the negative electrode. So the more distal is the negative, and proximal is going to be the positive electrodes, which is called as the cathode. The distance between these 2 electrodes from center to center should be 3 to 6 centimeter. And from where we are going to place my negative electrode, that is my first electrode, so it should be 1 centimeter, 1 centimeter proximal to the crease. So this is my palmar crease, which we can see. So 1 centimeter proximal to that, we can put my first electrode, which is negative electrode, and after that I have to put the second electrode, which is my positive electrode. The distance between these 2 center are 3 to 6 centimeter. So how do we know that this is the peripheral, this is the ulnar? In this, we can also do the mapping of the nerve. We have the different device for that also, which is the nerve. We can do the mapping of the ulnar nerve before the placing these electrodes. Ma'am, next slide, please. Ma'am, next, this we will cover. Okay, so that was the placement of the electrodes. So those were the site where we are going to place the electrode. So we basically have a different relationship of the muscles and the activity of my muscles of my larynx and the pharynx. So what it is, we have the orbicularis oculi muscle here, and that is more closely related with the activity of diaphragm. The second thing is we have the adductor pollicis muscles, which is basically reflecting my peripheral muscle sensitivity. So if adductor pollicis muscle is working, that means peripheral muscles has been recovered from the neuromuscular blockage. Same with the orbicularis. If the orbicularis oculi muscle contract, that means the most closely the diaphragm activity may have been resumed in the patient. The third thing is the recovery of the laryngeal muscles. We have the laryngeal muscles. So recovery of the laryngeal muscles will take longer time as compared to that of the diaphragm. So diaphragm is the first muscle which is going to get paralyzed, and this is the first muscle which is going to get recovered also because of the good amount of the blood supply. So laryngeal muscle will take more time from the diaphragm. So diaphragm will be first is going to get recovered, and then the laryngeal muscle is going to get recovered. So if we extubate the patient by saying that the diaphragm has been recovered, it may be that laryngeal muscles has not been recovered properly, and the patient can land up into the spasm, or there can be the desaturation which can be present in the patient. So these are the laryngeal muscle which will take longer time than that of the diaphragm to recover. So diaphragm will recover early. Then the first nerve which I'm going to use is the first nerve which is used for the monitoring is the ulnar nerve. So this is the most commonly used nerve. So why it is most commonly used? Because it is a very superficial nerve. The second thing is it is very accessible also. And the third thing is the ulnar nerve, which is supplying most of the muscles of the hypothenile eminence and one of the muscle of the thenar eminence, which is my adductor pollicis muscle. So when this nerve gets stimulated, it is basically present on the ulnar side, and the muscle of the thumb is, so this muscle is going to contract. So the muscle will be present on the opposite side. So direct stimulation of the muscle will not be there. So that is why the ulnar nerves are most commonly used. So here I have written the same thing. The electrodes are best applied to the volar side of the wrist slide. So electrode placement, which is the ulnar nerve. So distal electrode we have to place 1 centimeter proximal to the wrist flexion crease. So 1 centimeter proximal to it, we have to place the distal electrode, which is located near the radial border of the flexor carpi alaris tendon. Then the third thing which I have written is the electrode spacing, that is the distance between the proximal and the distal electrode from center to center should be 3 to 6 centimeter. And when I stimulate this nerve, so there can be the thumb adduction which can be seen in the patient, and the finger flexion will be the response which I will be getting. So this is my first ulnar nerve monitoring. The second nerve which I can also use is my facial nerve. So facial nerve electrode placement, how do we do? So we have to place the 2 electrodes again, the negative electrode and the positive electrode. So the negative electrode can be placed directly in front of the can directly place over the nerve, which is in front of the tragus. And the second, which is the positive electrodes, has to place anywhere on the forehead. So this is the placement of the facial nerve. The third nerve is the posterior tibial nerve placement. So the posterior tibial nerve placement, again, these electrode has to placed close to the medial malleolus, and the negative electrodes can be positioned distally. So what is this nerve muscle relationship? So when I stimulate the ulnar nerve, the adductor pollicis muscle is going to contract. The second nerve which can stimulate is the posterior tibial nerve. So when I stimulate the posterior tibial nerve, so the flexor hallucis brevis muscle is going to get stimulated. And the third nerve which I can stimulate is my facial nerve. So facial nerve basically has the 2 branch which is supplying my eye. So the first branch is the zygomatic branch. So this zygomatic branch of the facial nerve, it is going to supply my orbicularis oculi. So when it will contract, there will be the closure of the eyelid. So when I stimulate the zygomatic branch of the facial nerve, the ocular orbicularis oculi muscle is going to contract, and the closure of the eyelid will be seen. The second branch of the facial nerve, that is the temporal branch of the facial nerve, which is going to supply my corrugator supercilii. So what is this corrugator supercilii? So when this corrugator supercilii is going to contract, the medial aspect of my eyebrow is going to contract, and that will lead to the wrinkling of the eyebrow, which can be seen. So whenever I stimulate the nerve, the 2 muscles is going to contract. One is orbicularis oculi, and this contraction of orbicularis oculi return will be corresponding to my diaphragm recovery, and this corrugator supercilii muscle recovery will be coordinating with my laryngeal muscle recovery. And when the adductor pollicis muscle has recovered, that means all the peripheral muscles has been recovered, and all the rest of the things have been recovered after this. The facial nerve stimulation requires very low intensity, which is only 25 to 30 milliampere, 25 to 30 milliampere current. If we can get facial nerve get stimulated. So this is all about the placement and the nerve stimulation. This all I have written the same thing. Diaphragm is most resistant to both the depolarizing muscle relaxant and non-depolarizing muscle relaxant. So it is going to require 1.4 to 2.4 folds of the muscle relaxant as the adductor pollicis muscle. So whatever concentration of adductor pollicis is required to getting blocked, 2 times more than that diaphragm will be requiring to get blocked. But this is the first muscle to get blocked because it has a very rich blood supply. So diaphragm paralysis and recover more quickly than that of the peripheral muscle. The second thing is, again, the same thing I have written. The response of the corrugator supercilii to the facial nerve stimulation reflects the extent of the neuromuscular block of the laryngeal adductor muscles. So corrugator supercilii muscle correspond to the laryngeal adductor muscles and the abdominal muscles. better response of the adductor pollicis to the nerve stimulation. So, which is better as compared to that of the adductor pollicis response by the ulnar nerve. Orbicularis oculi, again, same thing, more correlates more closely with the diaphragm. The adductor pollicis reflects the peripheral muscle sensitivity, recovery of the laryngeal muscles. Again, may take longer time than that of the diaphragm. The same thing that I have written again. These are the questions. So, what is the most commonly used nerve for monitoring? So, this is the options are facial nerve, ulnar nerve, femoral nerve, sciatic. So, the most commonly which we are going to use is the second, which is the
Dr. Neha, just a bit slow, please. Please slow. Give
Okay,
the
ma'am.
options very slowly and give the audience time to think to give the answers 40 seconds.
So first question is, what is the most commonly used nerve for monitoring? So we have four options. One is facial nerve, the second is ulnar nerve, the third is femoral nerve, and fourth is the sciatic nerve. So the answer to this question is ulnar nerve.
You have to give 40 seconds. You have to give 40 seconds for the answers to come. Please wait.
Yes, yes.
And screen coordinators, please find out who has given what answer and be in touch. So I think all of them have answered C, right? What is the most common option which has been opted for? I think maximum people have gone in for C. So that is not the right answer. Screen coordinator, Dr. Jyoti, please be seeing what are the options.
Ma'am, yes,
opted
most of the
for.
students have answered C, but many of them
But that is
have
not
answered
correct. So the
also.
answer is ulnar nerve. So why is it the ulnar nerve? Can you explain that?
Yes, ma'am. So this is the most commonly nerve which is used is the ulnar nerve because it is more superficial. And the second thing is it is most easily accessible. And the third thing is we have this ulnar nerve. So ulnar nerve basically supplying the hypothenor eminence. But one of the muscle it is going to supply the thenar eminence is my adductor pollicis muscles. So when I stimulate my nerve, it is going to contract the muscle on the opposite, which is of adductor pollicis muscle. So there won't be any direct muscle stimulations. So that will not be seen with the ulnar nerve. So that is why we are using ulnar nerve because of easy accessibility and it is superficial.
Okay, move on to the next question.
The next question is which nerve is monitored when we stimulating the ulnar nerve? So we have four options. The first option is the orbicularis oculi. The second option is my diaphragm. The third option is adductor pollicis. And the fourth option is masseter.
Most of the students are answering C.
Repeat the options once more, Dr. Neha. Slowly. Go slow.
Yes, ma'am. Yes, ma'am. So the first option is orbicularis oculi. Second option is diaphragm. Third option is adductor pollicis. And fourth option is masseter muscle.
Dr. Jyoti, just see who has given the answer first.
Ma'am, Dr. Sharad has answered first.
Dr. Sharad.
Yes,
Okay.
ma'am.
Okay. So audience, please type your answers in the chat box. Are the answers coming?
Yes, ma'am. All of them are answering correctly only.
How do you know it is correct? Still, she has not told the answer.
Yes, ma'am.
You have leaked out the answer, Jyoti?
No,
Okay,
ma'am.
so can you tell us the answer, Dr. Neha?
Yes, ma'am. So option C is correct. The ulnar nerve basically stimulating the adductor pollicis muscle. And this orbicularis oculi will be stimulating with the facial nerve.
Okay.
Okay. So shall I start, ma'am?
Yeah, please.
There are 5 stimulation basically we are getting when we are using the peripheral nerve stimulator. So the first is my single twitch stimulation. So what is this single twitch stimulation? This is the single electrical stimulus which we are going to apply the peripheral motor nerve. So only one electrical stimuli we have to apply. The frequency of this electrical stimuli can range from 0.1 Hz to 1 Hz. 0.1 means we have to give it every 10 seconds, and 1 Hz frequency means we have to give it every second. Then we have what we have to do. We have to evaluate the muscle response. Most commonly, which we are using is the single twitch. Before ऊपर मैम yes, and the muscle response which is going to get evaluated. So where we are using this single twitch stimulation, so this can be used as a component of the PTC stimulation. So the first use of this single twitch, so I have explained it later. So it is the PTC. In PTC stimulation, we are going to use the single twitch. The second use of this is to know the supramaximal stimulus. So we will give the stimulus to the nerve, and at some point where all the muscle fibers is going to contract. So that will be my threshold, and 15 to 20% above which will be my supramaximal stimulus. So this can also be calculated by using this single twitch stimulation. Then the third use can be, it can be used to evaluate the time of onset of the neuromuscular blockade. So in this diagram, I have shown there is a stimulation. So stimulation can range from 0.1 to 1 Hz, but most commonly, which we are using for the single twitch is the 0.1 Hz. We can have the two type of the response. There can be the non-depolarizing block and the depolarizing block. So when it is a non-depolarizing block, there is a property of a fade. So when we give the single twitch, then the fade which can be seen. With the depolarizing block, there won't be any fade. Either they will get stimulated, all the muscle is going to contract, or if they are under the intense block, it will not get contract. So this is the single twitch stimulation. The next slide, ma'am. So before going to this question, I will discuss first the second pattern of stimulation, which is the train of 4. Train of 4 stimulation. So this is the train of 4. So what is the train of 4? So train of 4 is we have to give 4 supramaximal stimuli. So from the single twitch stimulation, we will know the supramaximal stimuli. And with the train of 4, we have to give the 4 supramaximal stimuli. And that has to be given every 0.5 seconds. So means the total duration is going to be 2 seconds. And each is having a frequency of 2 Hz. And each stimulation in the train causes the muscle to contract. What we have to assess? We have to assess the train of 4 count. So what is this train of 4 count? So it is the amplitude of my fourth response, which I will be getting, and divided by the amplitude of the first response, which that is the train of 4 ratio. So if the muscle is not paralyzed, so that means if I have not given any depolarizing muscle relaxant or the non-depolarizing muscle relaxant, so all the 4 amplitude is going to be same. So the train of 4 ratio in this condition is going to be 1, because amplitude of fourth response will be same as that of the amplitude of the first response. So the train of ratio is going to be 1 if no blockade had been given. Then we have the two conditions. Either we are going to give the depolarizing muscle blockade, or the second can be the non-depolarizing muscle blockade can be given. So in this diagram, we can see if the non-depolarizing muscle blockage I am giving to the patient. So if the patient is under the intense block or the deep block, all the 4 stimulus will not be seen. So when you see this non-depolarizing block, so when we have given the stimulus, the 4 stimuli which can be given, and after that you can see if there is a blockade, not even a single response we will be going to get. But suppose if the patient is recovering, so if the patient is recovering in that conditions, there will be the response, there will be the good response to the first, and then the height of the next stimulus is going to be reduced. This is called as the fade phenomena. So what is this TOF ratio? This is the amplitude of the fourth stimulus divided by the amplitude of the first response which we are getting. This is called as strain of 4, and we can see with the non-depolarizing muscle blockade, there is a fade which we can be seeing. So that I have written during a partial non-depolarizing muscle blockade, the train of 4 ratio is going to decrease. That means the fade which can be seen in the patient. Then the second response is going to be my depolarizing muscle blockade. So when I give the depolarizing muscle blockade, either with all the 4 stimulus, the muscle is going to contract, or either they will not contract. So when they will contract, they can have the height of all the 4 will be going to be same. So the train of 4 ratio is going to be 1, because the fourth amplitude and the first amplitude will be same. So even if it is decreasing, when we give the depolarizing muscle blockade, the height of all the 4 stimulus is going to be same. So ratio will always be going to be, train of 4 ratio will always be going to be 1. But the train of 4 count can be either 0 or either 4. So either you will be able to appreciate all the 4 stimulus. So the train of 4 count can be 4, or you will not be able to appreciate any one of the stimulus. So the train of 4 count is going to be 0. But the ratio of this, so fourth amplitude and the first amplitude will always be same in the depolarizing muscle relaxant. So the train of 4 count is going to be 1. So this I have written. So during the partial depolarizing muscle blockade, no fade occurs in the train of 4 response, and the train of 4 response either remains 1 or 0. So all the amplitude will be going to same. So it is going to be 1 only, independently of the level of the depolarizing neuromuscular blockade. So whether it is a deep block or the patient is recovering, so every time the ratio is going to be 1 only, because the height of all the 4 stimulus is going to be same. But suppose if the patient has undergone the phase 2 block in the depolarizing muscle relaxant, in that condition we can see the fade phenomena. We have to, so the interval between the two TOF, so one I have done TOF, and another time if I want to do, so the interval should be at least 10 seconds. So this I have written, interval of at least 10 seconds should be allowed between each set train of 4 stimuli to avoid fade during the measurement. So if it is a non-depolarizing muscle relaxant, the train of 4 is going to show the fade, and if it is a depolarizing muscle relaxant, it will not show any fade. But if the depolarizing muscle relaxant undergo the phase 2 blockade, it will show the fading. So what are the advantages of doing this train of 4, and what is the disadvantages? So the advantages of this will be, so during the neuromuscular blockade, so the degree of block can be directly measured from the monitor. The second thing is it can tell about the onset, the surgical relaxation, and the neuromuscular recovery. The third thing is it allows the reliable assessment of the onset of the neuromuscular block and can be taken as a measure of the neuromuscular recovery from the non-depolarizing blockade. So by seeing the train of 4 ratio, if the ratio is more than 0.4, that we know, that I have discussed later. So that means the patient is recovering. So by looking at the train of 4, we can see whether the patient is under the intense block or deep block, or maybe recovering from the blockade. It is less painful as compared to that of the tetting stimulation. So that in the next slide, we will see the tetting stimulation. It is less painful than that of the tetting stimulation. And also the subsequent monitoring of the neuromuscular block will not be getting affected by this train of 4. We have to give a duration in between these two TOF monitoring of 10 seconds we have to give. What is the disadvantages? So disadvantages of the train of 4 is basically it is a subjective assessment. Subjective assessment means what? So when the train of 4 ratio is less than 0.4, so that means when it is less than 40%, we can correctly see if it is under the deep block or the intense block. But if the train of 4 ratio is between 0.4 to 0.9, the fade cannot be detected either visually or technically. So for me, that train of 4 can be 50%. For another individual, it can be the height of the fourth amplitude. For me, can be 50%, but for another individual, it can be 60%. So it is basically a subjective assessment. So if I'm doing the train of 4, the objective monitoring devices can be needed. The third thing is the TOF ratio cannot quantify the intense and the deep level of neuromuscular blockade. So when I do the TOF, I cannot say whether it is an intense neuromuscular blockade or whether it is a deep neuromuscular blockade. The fourth thing is the TOF stimulation does not allow monitoring of the phase 1 blockade of the depolarizing muscle relaxant, because there is no fade which will be seen with the depolarizing muscle relaxant, every time the TOF ratio is going to be 1. So because the amplitude of all the 4 stimulus is going to be same with the depolarizing muscle relaxant, so it is always going to give a value of 100%. So we cannot monitor the phase 1 blockade of the depolarizing muscle relaxant. So now I have what is the application of this TOF? So suppose if I have given the non-depolarizing neuromuscular blockade to the patient and I am doing the TOF monitoring. So I can monitor the different level of the block. So first is the intense block. So if intense block or the profound neuromuscular block occurs within 3 to 6 minutes of an injection of an intubating dose of non-depolarizing muscle relaxant. So when I give the non-depolarizing muscle relaxant to the patient within 3 to 6 minutes, I am going to get the intense block. So when there is an intense block, this phase is called as the period of no response. Means what? So the train of 4 ratio in this is we are not getting any train of 4 because of the intense block. Not even a single muscle is going to contract. So this is called as the period of no response. So nothing will be seen on the train of 4. It cannot be antagonized. So if I try to reverse these patient who is under the intense block, who does not have any train of 4 or the train of 4 ratio is 0. So with the new regimen, it will not be getting reversed. The second thing is if I'm using the rocuronium, pencuronium or vecuronium, so high doses of the Sugamadex, which is 60 mg per kg, can be used to antagonize these intense block. But the use of the new regimen is not going to reverse this condition, which is the intense block. So in the intense block, I'm not getting the train of 4 ratio, which is 0. And the second thing is which I have covered in another slide, which is the post-tetanic count. So which is also not be seen in the intense block. The second block, if I give the non-depolarizing muscle relaxant, can be the deep neuromuscular block. So what is this deep neuromuscular block? So after the intense block, there is a period of a deep neuromuscular blockade. So this is again characterized by the absence of response to the train of 4 stimulus. So again, even if I apply the train of 4, the muscle is not going to contract. So train of 4 response won't be there. But in this, there can be the post-PTC stimulation can be there. So what is this PCT? This is the post-tetanic count. So 1 or 2 PTC you can get in this deep neuromuscular block, but the train of 4 ratio is going to be 0. So why we do this? Why we need this deep neuromuscular block? To avoid any diaphragmatic movement, to ensure surgical stillness, and to improve the surgical space condition during the laparoscopy. So suppose if there is an eye surgery, which is the retinal surgery or the ocular surgery, in that condition, the eye should be still. So for that, we are going to maintain it under the intense block or the deep neuromuscular block. The third for the abdominal procedure, the PTC count recommended, which is less than or equivalent to 3. Duration of this, so how do we know whether it is an intense block and whether it is when the deep block is starting? So duration of the deep neuromuscular block is difficult. So there is a correlation exists between the PTC stimulation and the time until the reappearance of the first response to the TOF. So when we do the PTC stimulation, so which will be covered in next slide. So the interval between that PTC, so suppose the 1 or 2 PTC count is there and the first response. So when I give the TOF, or when I give the 4 maximal stimulus to the patient, and the first response, if I will be able to see, that will be the interval of the deep neuromuscular block. Again, a reversal with the new stigmin is not possible in this. And if I have given the rocuronium or the vecuronium, so that I can antagonize with the Sugamadex with a dose of 4 mg per kg. The third type of the blockade which can be seen with the non-depolarizing muscle relaxant is the moderate level of neuromuscular block. So what is this moderate level of neuromuscular block? So in the deep block and in the intense block, there won't be any train of 4 count. But now in the moderate level of the neuromuscular block, which is required for most of the surgical procedure, the first response to the train of 4 stimulation appears. So when I give the 4 supramaximal stimulus, it is going to respond to the first stimulus. For the another 3 stimulus, it may or may not be muscle may or may not be contracting depending upon the recovery. So when it is going to start, so the moderate neuromuscular block is going to start when there is a first response to the train of 4 stimulation. When only one response to the train of 4 is detectable, that means the degree of neuromuscular blockade is 90 to 95%. And when the fourth response appears again, the neuromuscular blockade is of 60 to 90%. So what it is important is if the trig ratio of 1 or 2 is present. So if I giving the 4 supramaximal stimulus and the patient is responding to first stimulus and the patient is responding to second stimulus, so that means the patient is under the sufficient relaxation for most of the surgical procedure. During light anesthesia, the patient may move, buck or cough. Therefore, a deeper block is necessary for the facilitations of the surgery. So if the train of 4 ratio is 1 or 2, the patient is under the sufficient block for the surgical procedure. Now, if I try to reverse this patient who is having the moderate neuromuscular block. So in this moderate level of neuromuscular blocking, so the first response to the train of 4 stimulation is there, and the PTC count will also be there, which can be around 8. So in the first, when there is an intense block, there is no train of 4, there is no PTC. In the deep block, there is no train of 4, and the PTC is going to be less than equivalent to 3. But when this is the moderate neuromuscular blocking, so there will be the train of 4 response, and there will be only first or second response will be there, and the PTC count can be around 8. So that can be there. So when I try to reverse it with the new treatment, so this also will not be getting reversed easily. And we can reverse the rocuronium or the pancuronium with the Sugama Dex, which is of 2 mg per kg. When should we start a new treatment? So we should give the new treatment for the extubation should be given when all the 4 response after the train of 4 stimulation has observed. So when all the 4 stimulus we are going to see on the train of 4, then only we are going to give the reversal to the patients with the new treatment. Okay, and this you cannot antagonize this moderate level of the block with the new treatment. We have to give the Sugama Dex if I have given the vecuronium, rocuronium, or pancuronium, so with a dose of 2 mg per kg. The another thing is the how to see for the train of 4 ratio. So the train of 4 ratio can be I have taken 5 figures. So the train of ratio can be 0.4 or less. So if my train of 4 ratio on my peripheral nerve stimulator is less than 4, that less than 0.4, that means less than 40%. That means what? So 3 things it will tell. So patient is unable to lift the head or arm. So patient won't be able to lift the head or won't be able to lift the arm. The second thing will be the tidal volume of these patients can be normal, but all the vital capacities and the inspiratory force in these patients are going to be reduced. So we should not try reversal at this stage. The second TOF ratio, suppose if it is 0.6. So now the patient is able to lift their head for 3 seconds. So the patient can lift the head for 3 seconds and they can open their eyes, they can stick out their tongue. Now still the vital capacity and the inspiratory force are reduced. If the TOF ratio is 0.7 to 0.75, so now the patient can cough and can lift the head for at least 5 seconds, and the grip strength is low, but it is 60% of the control. But when the TOF ratio is more than 0.8, now the tidal volume is normal, vital capacity and the inspiratory forces are normal. And the patient can have the diplopia or can have the blurring of the vision, or the facial weakness can be there with the train of 4 ratio 0.8. But if the train of 4 ratio is more than 0.9 or that is 1 or more than 0.9 or 1, so now we can give so it will exclude the residual neuromuscular blockage. So there is no residual blockage will be seen, and we can give the new treatment and extubate the patient. Okay, so what if there is a residual blockage? So when we give the non-depolarizing muscle blockade or any neuromuscular block, so what will happen if the residual block is left? So there is one receptor which is present in my carotid body, which is the nicotinic acetylcholine receptor. So if there is a residual block, so these residual drugs is going to go and act on this nicotinic acetylcholine receptor, which is present in my carotid body and which is going to impair its chemosensitivity property to hypoxia. So what normally happens when the patient is having the hypoxia, it is going to go and activate the chemo sensitive centers, and it will increase the RR of the patient, or the patient respiratory centers get stimulated and the RR will increase and the patient will undergo hyperventilation to wash off the CO2. So this was a normal response which will happens. But if there is a residual block, that is going to impair my carotid body, which is going to impair its response to the hypoxia, and it is not going to stimulate the respiratory center. So the patient will land up into the arterial desaturation. So this is the disadvantage. This is the effect which we get if there is a residual block. The second thing will be, So if there is a residual blockage which is less than 0.9, so there can be the pharyngeal muscle and the laryngeal muscle weakness. So if there is a weakness of these muscles, so increased chances of the aspiration, increased chances of the regurgitation of the gastric content can be seen. The third thing with the residual blockage is, so suppose if there is a residual blockage, when the TOF is less than 0.7 and we have extubated the patient, so that can be a risk factor for the development of the post-operative pulmonary complications. And fourth thing is, if there is a partial neuromuscular recovery, so upper airway can get collapse and all the inspiratory volumes can be less in the patient, and further the patient can be saturated. So this is all about the TOF monitoring. If we are giving the non-depolarizing muscle relaxant. The TOF monitoring when we are going to give the depolarizing neuromuscular block. So depolarizing muscle block, we have the two things. We have the phase 1 block and we also have the phase 2 block. So what is with the phase 1 block? So I know when I give the TOF, when I press the TOF button on the peripheral nerve stimulator, so what will happen if it is a depolarizing muscle blockade, the TOF ratio is going to be 1. So the height of all the 4 stimulus is going to be same. So if it is a deep block, there won't be any height which will be seen. So the TOF ratio is going to be 0. But if they are recovering, all the 4 stimulus will have the same height. So the TOF ratio is going to be 1. So monitoring of the depolarizing muscle blockade cannot be done. So suppose if we are getting the stimulus on the visual stimulus on the my peripheral nerve stimulator, that means the patient can be at a different level of block. So it can be in a deep block or the patient has come out. So the recovery has been started. So we cannot quantify the level of the block with the TOF if we have given the depolarizing muscle blockade. But suppose if I'm giving the depolarizing muscle blockade and if the phase 2 block has occurred, so in that condition, we can see the fading phenomena which is normally seen with the non-depolarizing muscle blockade. So phase 1 block occurs with the depolarizing muscle relaxant. The response to the trainer 4 or the tetanic stimulation does not fade. So again, the fading will not be seen and there won't be any post-tetanic facilitation of the transmission which is occurring. All the 4 responses are reduced to the same degree. So the trainer 4 ratio, either there won't be any response to the 4 stimulus which I am giving. So the trainer 4 ratio is either going to be 0 or all of them is showing the response, but the amplitude of all the 4 is going to be same. So the TOF ratio is going to be 1. No fading will be seen. But suppose I am giving the depolarizing muscle relaxant to a patient who is having the abnormal level of the plasma choline esterase activity. So what is this plasma choline esterase? So this plasma choline esterase which is going to degrade my scoline. So when I give the scoline, it will be degraded in the blood itself with the help of the plasma choline esterase. Then it is going to go and reach the neuromuscular junction. But suppose if the patient is having the abnormal plasma choline esterase activity, means what? This succinylcholine choline will not be getting metabolized into the plasma, and this the dose which we have, suppose that it is a normal dose, would be excess for these patient who is having the abnormal plasma choline esterase activity. So more amount of the succinylcholine is going to go and bind to the acetylcholine receptor. When they bind, what will happen? They can enter into the phase 2 block. So because large amount of the succinylcholine which is reaching the receptor can lead to the desensitization or can lead to the channel block, and that will be responsible for the phase 2 block. So now this phase 2 block will act as a non-depolarizing muscle blockade. So the same trainer 4 ratio, the fading which can be seen if there is a phase 2 block with the depolarizing muscle relaxant. So that I have written in the third point. So patient with the abnormal. So if the patient is having abnormal plasma choline esterase activity, who are given the same dose of the succinylcholine, undergo a non-depolarizing light block. So initially succinylcholine will be more. So the trainer 4 stimulus will be seen, and later on the succinylcholine will be getting reduced. So the fading will be seen just like that of the non-depolarizing muscle relaxant. So it is characterized by the fade in response to the trainer 4 and the tetanic stimulation that I have covered later on. Occurrence of the post-tetanic facilitations which can be seen. So the non-depolarizing depolarizing muscle relaxant with the abnormal plasma choline esterase activity can have the fading phenomena, can have the post-tetanic stimulations like that, which is called as the phase 2 block. Next slide, ma'am. So suppose So if the patient is having the atypical plasma cholinesterase activity, so if I try to reverse this patients with the new regimen, so if we give the new regimen, so this new regimen can potentiate the block dramatically, temporarily improve the neuromuscular transmission, and then either potentiate the block or partially reverse it. So if these patients are tried with the new regimen in phase 2 block, so either there can be the potentiation of the block or there can be the partially recovery, depending on the time which is elapsed since the administration of the succinylcholine choline dose of the new regimen which is given. Unless the cholinesterase genotype is known to be normal, antagonism of the phase 2 block with the cholinesterase inhibitor should be undertaken with the extreme caution. So even if we are giving, we have to monitor the patient for 1 hour. This is my third stimulation. So the first single twitch stimulation, second was the train of force stimulation, and this is the third stimulation, which is the technique stimulation. So what is this stimulation? So it consists of a delivery of a high frequency electrical stimuli. So we have to give the 50 hertz of the stimuli, and that has to be given for the 5 seconds. So this is most commonly 50 hertz is given for the 5 seconds. So again, what will happen? If I'm giving the depolarizing muscle relaxant, so with this much of stimulus, all the muscle is going to contract. So there will be the sustained contraction and all the muscle will relax. So there won't be any fading. But if I'm giving the non-depolarizing muscle relaxant, so in the non-depolarizing muscle relaxant, it detects one strong sustained muscle contraction and fade after the tetting stimulation. So initially there will be the contraction and later on the contraction will decrease, due to which the fading will be seen with the non-depolarizing muscle relaxant. So what is this fade? So fade is usually seen with the non-depolarizing muscle relaxant. Why? Because this fade phenomena is associated with the acetylcholine receptor, which is present presynaptically also. So if the acetylcholine receptor, which is present presynaptically, so what it does? So normally what happens in the presynaptic nerve, so we have the presynaptic nerve terminals, then we have the synapse, and then we have the postsynaptic nerve terminals. So in the presynaptic nerve terminals, we have the synaptic vesicles in which the acetylcholine has been stored. So this acetylcholine, when there is a nerve stimulation, is going to get released and it will be present in the synapse. And if there is a less amount of the acetylcholine, what it will go? It will go. There will be the positive feedback, and this acetylcholine receptor, which is present presynaptically, is going to get activated, and this is further going to release the acetylcholine in the synapse. But later on, with the accumulation of the acetylcholine, what will happen? There will be a negative feedback to again this acetylcholine receptor, which is present presynaptically, and now it is going to reduce the amount of the acetylcholine. So initially, what is happening? Initially, there is a more amount of the acetylcholine which is getting released from the presynaptic terminals, and later on, because of this negative inhibition of the presynaptic acetylcholine receptor, the amount of the acetylcholine is decreasing. So the fade will be seen. So this I have written. So what is this? Application is the fade. So when I do the technique stimulation, what will happen? This all the neurotransmitter from the presynaptic is going to get released into the synapse. There will be the positive feedback, and again the remaining acetylcholine is going to get released. After some times, when the technique stimulation is over, the acetylcholine in the synapse will be more. It will send the negative feedback, and now the release of the acetylcholine will get reduced, due to which the patient will have the there won't be any contraction. So fade in response to the, so this application is the fade in response to the technique stimulation is a presynaptic event. So it is a presynaptic event at the start of the technique stimulation. So when I do give the technique stimulation, when I give the 50 hertz for 5 seconds, what happens? Large amount of the acetylcholine are released from immediately available stores, which is the synaptic vesicles, which is present in the presynaptic nerve terminal. And this rate of the release of the acetylcholine will be decreased further. It is decreasing further because of there is a inhibition of this presynaptic acetylcholine receptor, which is decreasing the level of the acetylcholine release. So there is stimulation, and after that there will be the paralysis. So when the margin of the safety at the neuromuscular junction is reduced, fade become evident. So this is the post. What will happen? A typical reduction in the twitch height is seen with the fade, especially during the repetitive stimulation. So once I stimulate, there will be the response, and later on, if I try to stimulate, there is no acetylcholine, there won't be any response, and the fading will be seen. So in addition to this post-synaptic block, so we know the non-depolarizing muscle relaxant is going to go and block the acetylcholine receptor, which is present post-synaptically. This non-depolarizing muscle relaxant can also block the presynaptic neuronal subtype of the acetylcholine receptor, and thereby leading to impaired mobilization of the acetylcholine within the nerve terminal. So now this acetylcholine will not be getting released and the fade will be seen. So that is why with the non-depolarizing muscle blockade, the fade phenomena is visible because of the inhibition of this presynaptic acetylcholine receptor. So this contribute to the fade in response to the technique stimulation, or whether it is a train or force stimulation. So the fade will be seen. What is the application of this twitch stimulus? It is a very painful stimulus. So we can give the twitch stimulation only as a component of a DBS. So that will be the next topic, and the PTC stimulation. So when I want to do the PTC stimulation, which is the post technique count, or when I do the DBS, this twitch stimulation is it's one of the component. It is used again. It is used to evaluate the residual neuromuscular block, but it is very painful. So this is the same thing. This is the twitch stimulation. So this is the twitch stimulation which has been given, that is of the 50 Hertz stimulation has to be given to the patient, and that has to be given for a period of 5 seconds. So we see if it is a non-depolarizing muscle block, there will be the fading. So the fading will be seen, while in the patient with the depolarizing muscle block, either the stimulus height is going to be reduced. There won't be any fading with the twitch stimulation, because there is no fade with the depolarizing muscle relaxant. Why? Because the non-depolarizing muscle relaxant, which is inhibiting the presynaptic acetylcholine receptor, the depolarizing muscle relaxant is not inhibiting the presynaptic acetylcholine receptor. That is why there is no any fade, which won't be seen with the depolarizing muscle relaxant. Next topic is the fourth stimulations, which I'm going to give is the post-tetany count. So this is a question. Post-tetany count is used to assess. So there are 4 options. One is the light blockade. The second is the patient is having moderate blockade. And the third is if the patient is having deep blockade. And fourth is there is no blockade. So these are the 4 options. This is about the post-tetany count. So when to use the post-tetany count?
has answered C.
So the answer is deep blockade. So this will be my next topic. Post-tetany count we used to do to assess the whether deep blockade is there is not. So this is my 4th stimulation, which is the post-tetany count. So what is this post-tetany count? So the post-tetany count is basically again the tetany stimulation which was dealt in the previous topic. So we will give the tetany stimulation to the patient, which is of 50 Hz, has to be given 45 seconds. And then you have to wait for the 3 seconds. After waiting for the 3 seconds, you have to give at least 10 to 15 single twitches, which is called my post-tetany twitch. And that has to be given at a frequency of 1 Hz. So first you have to give the single tetany stimulation of 50 Hz for 5 seconds. Then you have to wait for 3 seconds. And after this 3 seconds, you have to give the 10 to 15 single twitches with a frequency of 1 Hz. So what will we see? So again with the post-tetany count. So post-technique potentiation. So again, this is the same with the post-technique like that of the technique stimulation. So technique stimulation leads to a transient exaggerated release of the acetylcholine that act at the motor end plate, and this forms the basis for the evaluation of the post-technique count. So I have mentioned it in the next slide. The how to what all are the inferences with the post-technique count. So what is the application? So suppose if I have given the non-depolarizing muscle relaxant to the patient and I want to do the post-tetany count. So we have to give the tetany stimulation, which is 50 Hz, has to be given 45 seconds. Then we have to give the 10 to 15 post-tetany stimulation of 1 Hz. What we will be seeing if with the non-depolarizing muscle block, if there is an intense block, there is no response to any technique or to any post-tetany stimulation if it is in the intense block. So I have mentioned it previously also. If there is an intense block, no train of 4, no PTC counter. But as the period of the intense neuromuscular block dissipates, so the after the intense, there will be the deep neuromuscular block. So when they come, as the period of the intense neuromuscular block dissipate, the first response to the post-tetany twitch stimulations occur. So when there is a deep neuromuscular block, now the person can have stimulation can have the 1 or 2 count which can be there with the deep blockade. But if it is a moderate level of the block, or so this I have written, if the PTC count is less than equal to 3, so that if there is no PTC count, there is an intense blockage. If the PTC count which I'm getting is less than equivalent to 3, it is going to be the deep level of the blockade. But if the PTC count is between 6 to 10, that means the first stimulus to the train of 4 is now present, and this is the moderate level of the blocking. So this moderate level of the blocking is required for most of the surgical procedures. So this is the application of the post take count. Because the last line is the tetanic stimulation should not be performed before 6 minutes. So if you have done one tetanic stimulation and the PTC, we have to wait for the 6 minutes for the another tetanic stimulation, so that the recovery of the acetylcholine and muscle should be there. Then again, this I have written. So during the intense block, there is no response to any form of the stimulation. During the deep block, there is no response to the train of 4, but the post-tetanic facilitation of the transmission can be present. There can be 1, 2, 3 post-tetanic facilitation. Then the third thing is if there is a surgical block. So if there is a surgical block, the PTC can be 8, and there can be the first response to the train of 4. So this is how we see for the non-depolarizing muscle blockade. And with the depolarizing muscle blockade, this we do not do, because there is no fading. So then this is the same thing with the PTC. So the post-tetanic count. So this is the train of 4 ratio which we are giving. So these are the level of the block. So suppose the patient is in the intense block. I am giving the train of 4. There is no response. So that means the patient is under the intense block. The second thing is I am doing the PTC. So what it is, I am giving the tetanic stimulation, which is followed by the post-tetanic count. And again, there is no response. So that means the patient is under the intense block. The second thing is the deep block. So deep block having 2 parts, B and C. So what is this? So when I'm giving the train of 4, again, no response in the deep block. In the C also, when I'm giving the train of 4, there is no response. But in the B, we can see when I'm giving the post-tetanic count. So the post-tetanic switches, if I'm giving, there is a 1. So this is the post-tetanic count of 1. And in the C, this is the post-tetanic count of 3. So 1, 2, 3, there is no train of 4, but the post-tetanic count of 1 or the post-tetanic count of 3 is under the deep block. The third thing is the surgical block, which we are requiring in most of the surgical procedure. So when I give the train of 4 now, this is the first response to the train of 4. So now the train of 4 response, either 1 or 2, is good for the most of the surgical procedure. And this is the PTC. So the post-tetanic twitches. So in the post-tetanic twitches, so multiple, around 8 to 10 post-tetanic count will be seen in the moderate level of the blocking, which is required for the surgical block. This is how to use. Then these are the two questions. The first question is, which type of the neuromuscular block shows the fade on stimulation? So we have the 4 options. We have the depolarizing agent, we have the non-depolarizing agent, we have the local anesthetic, and we are having the opioids.
For the first question, answer is B. Dr. Sandeep has answered B. Prashant is saying B. Most of the people are answering B.
So yes, so the train of 4 ratio or the fading can be seen with the non-depolarizing agent, with the depolarizing only if there is a phase 2 block. Next question is, which of the following indicate the residual neuromuscular blockage? So there are 4 options. Residual neuromuscular blockage, which will indicate if the train of 4 ratio more than equivalent to 0.9, sustained tetanus, or the train of 4 ratio less than 0.9, or if there is a strong muscle contraction.
Most of the people are answering C. Dr. Anisha Gupta is saying C. Rajesh C. Prashant C.
Yes, ma'am. So yes, this is the last stimulation which we are going to do. So this is my double burst stimulation. So what is this double burst stimulation? So we have a stimulation.
Dr. Neha,
we have the
Dr. Neha, we're already much beyond the time. So you just tell in brief about double burst stimulation.
Okay, this is last slide, ma'am.
Okay.
So this is my double burst stimulation. So what is this? We have to give the 2 bursts of the 50 hertz, and each burst will have 3 impulses. So what we have to do, we have to give the 2 bursts. With the 2 bursts, so one burst is of the 50 hertz, and the second burst is also of the 50 hertz, and the timing gap between them is by the 750 milliseconds. And then so the stimulation pattern is going to be, so it consists of the 2 short bursts of 50 hertz technique stimulation, which is separated by 750 milliseconds with a 0.2 milliseconds duration of each square wave impulse in the burst. So I'm giving 2 bursts to the patient of the 50 hertz with the duration between these two of 750 millisecond. And in each burst, the 3 impulses we are giving. That is why I have written the DBS 3 mode. So in each burst, I am giving 3 impulses with a duration of 0.2 milliseconds. So again, if I'm giving the double burst stimulation, so I'm giving the 2 stimulations. So if there is so in the interpretation, if there is a non-paralyzed muscle, so both muscle contractions are of equal strength. So when I give the 2 bursts, the contraction will be of equal strength. But if it is a partially paralyzed muscle, so the second response is going to be weaker than that of the first, and it will correspond to the phenomena of fade. So this is my last slide. Thank you so much, everyone, for listening.
Thank you, Dr. Neha. We will take now questions. First question is from Dr. Muthu Kumar. Does electrolytes change influence our monitoring of NMJ? If so, how do we know?
Ma'am?
Can I repeat the question? What is the effect of electrolytes on the monitoring of neuromuscular junction?
Ma'am, usually, if we are giving the depolarizing muscle relaxant, so we can worry about this level of the electrolyte, that is of the potassium, or if there is a history of a burn. Otherwise, for the normal monitoring, the electrolyte is usually not necessary. But if there is a burn history, or I'm using depolarizing muscle relaxant, for yes, we have to do electrolyte monitoring for checking the level of potassium.
Okay, thank you. Is there any other question? Participants, audiences?
Ma'am?
I don't think there is any
I think we have already had an extensive presentation on neuromuscular monitoring. So sorry for the glitch. I think we had a very interesting topic of intestinal obstruction, which had started, but which we had to stop in between because of an technical glitch. So we apologize for that. And the next class, we will be covering the very important topic of intestinal obstruction. Okay. So barring that, regarding the discussion on neuromuscular junction monitoring. So that was a very extensive presentation. So my question to Dr. Neha, are you there online?
Yes, ma'am.
Yes. So you have covered every aspect of neuromuscular monitoring in details. So I will ask you one very simple question. What is the main goal of neuromuscular monitoring?
Ma'am?
What is the ultimate goal or the main aim?
To look for the residual effect of the non-depolarizing muscle, the blocking agent which we are giving, so that if we do the extubation, there won't be any residual effect, ma'am. Especially in the eye surgeries, retinal surgeries, or ocular surgeries, movement of the patient is should not be there. So to do that, we do the monitoring, ma'am, neuromuscular monitoring.
Yes. So one of the most important goals is to prevent residual neuromuscular blockade. And why are we scared of residual neuromuscular blockade?
Ma'am, it can have various deleterious effects. So suppose if it is an obese patient, or if there is a respiratory compromised patient, and if there is a residual blockade. So I have explained it. It can stimulate the, it will act on the carotid body, And usually when there is a hypoxia, these carotid chemosensitivity will stimulate my ventilatory centers, and which can increase the respiratory rate and can wash out this PCO2. But if
So-
there is a residual block,
So what? So what? Let there be tachypnea. Let it get washed out. What is the problem? What is the
ma'am,
problem of residual neuromuscular block? What
hypoxia
clinical problems can it lead to? Hypoxia, yes.
arterial patient can desat, ma'am. And if it is obese patient, they already have less amount of FRC. So that will be deleterious to them, ma'am. Then again, if there is a residual blockade, the upper airway reflexes will not be there. Risk of aspiration, regurgitation will be there, ma'am.
Yes. Yes.
And collapse of upper airway can be there, which will further.
Yes. So there are high chances of aspiration and post-operative pulmonary complications, right?
Yes, ma'am.
And thereby delayed discharge from the post-anesthesia care unit and recovery.
Yes, ma'am.
Ma'am,
Okay.
there are few questions in the chat. Dr. Athira wants to ask, should we use neuromuscular monitoring routinely in liver or renal diseases?
See, when you say routine, okay, please
Yes,
answer.
No.
Even the faculty can answer. It is not necessary that only the postgraduate should answer. Anybody can answer. Yeah.
Madam, pharmacokinetics of neuromuscular agents are altered in renal and hepatic diseases, so we can go for monitoring.
Yes, in fact, we should go for monitoring. Yes, sir. Any other question?
Yes, ma'am. Dr. Sharad wants to ask, is nerve stimulator and nerve locator same thing or is it different?
Ma'am, nerve locator is usually for mapping of the nerve. To look for the location of the nerve, mapping of the nerve can be done with the nerve locator. Or peripheral nerve stimulator is for monitoring, ma'am, by after giving the blockade.
Dr. Sunpreet wants to ask, what are the risks of post-operative pulmonary complication?
What are the risks? It is already covered, no? There can be a risk of post-operative pulmonary complications such as, yes, Dr. Neha, which are the examples of post-operative pulmonary complications due to residual neuromuscular blockade?
Yeah, itself it is because of the FRC is always reduced, na? So already she has answered.
Yes. So there
Yeah.
will be collapse, there will be decrease in the FRC, huh? Go ahead.
Ma'am, Dr. Muthukumar wants to add that if TOP doesn't match drug doses, we need to suspect electrolyte, especially in PIH patient on magnesium. So he wants to add this point.
Yes, I think he had only asked that question also initially. Yeah. Anything else?
Ma'am, I think that's it.
Yeah, the Jaya ma'am, you want to discuss a topic?
Overall, just first of all, I really regret and I am very apologize for the inconvenience because of network issues. But actually, they have taken papers within a short period of time, and I think they have done the good PPT, good presentation, and most of the things she has covered. So I don't think there are much questions to be get asked, except the about the Sheetal's presentation is a little bit remaining.
Okay. So, madam, can I ask what to call it, gold medal question to your PG, Dr. Sheetal?
Yes, ma'am. Sheetal is our online, no?
No, Dr. Sheetal, because I think Dr. Neha must be quite tired now. Okay, Dr. Neha only can answer, no problem. Because I think Dr. Sheetal is busy with her intestinal obstruction.
No, ma'am, she is here only.
Yes. So, Dr. Neha, what are the, Dr. Neha? Where is she for my gold medal question?
Hey, ma'am.
You're there?
Yes, ma'am. Sheetal is also there, ma'am.
Okay, so do you know this? What are the signs of adequate reversal from neuromuscular blockade? Clinical signs. Forget neuromuscular monitoring.
Absolutely nice
Yes,
question.
ma'am. Clinically, by looking at the patient, for example,
Tell me 1, 2,
we are
3,
going
4.
to.
Tell me 1, 2, 3, 4 in brief.
Okay, ma'am. First is basically the patient will be able to uplift his head for more than 5 seconds. The second thing is the patient will be able to move his hand across the body for more than 5 seconds, ma'am. Then the peak inspiratory pressure, which is going to be around 40 to 50 centimeter, ma'am. This is the third point. Then we can tongue depressor test can also be done, ma'am. So we can put the tongue depressor in the mouth of the patient, and if we are removing and there is a resistance we are feeling, that means the patient muscles are working. So these are the signs, ma'am, we can do clinically for the adequate reversal of the patient.
And
What about hand
sustain.
grip?
Yeah,
Hand
sustained
grip?
hand
Ji,
grip.
ma'am.
That's what I think. Sustained hand grip.
Sustained hand grip and
Yes,
leg lift.
sustained hand grip will be there for 5 seconds.
And was that head lift or neck lift? What was it?
Head, ma'am.
It is a neck lift. Actually,
lift.
the neck muscles should be adequately recovered.
Okay, ma'am. Neck lift.
Okay, tell me, suppose the depth of blockade is very deep blockade. Okay. So what will be the post-tetanic count and what will be the train of 4 count?
Ma'am, if it is an intense block, so train of 4 we will not be able to appreciate. Same with the PTC, post-tetanic count, we will not be able to appreciate. But if it is a deep neuromuscular block,
It will, no, in short, when you're asked a question, you just give the answer to that. Don't go beyond giving me. It will be 0 or less or that much.
Train of
Post-tetanic count.
4 will be ma'am. There won't be any train of 4 if there is a deep blockade, ma'am. But post-tetanic
So
count
what
can
are
be
the
1 or
American Society of Anesthesiologists task force recommendations on neuromuscular monitoring? What are the important points in that? Have you read these guidelines?
No, ma'am.
So these guidelines are there. The ASA task force guidelines on neuromuscular monitoring, and they very clearly state that the train of 4 ratio has to be more than or equal to 0.9. That is very important to prevent residual paralysis. And they have said that monitoring the adductor pollicis is very important. That muscle has to be used. And they have advocated using Sugmadex over neostigmine for deep or moderate blocks, and also waiting 10 minutes after the reversal before extubation if you're doing a qualitative assessment of the neuromuscular block.
Okay, ma'am. Yes, ma'am.
I think we have had an extensive discussion. Rajiv Gupta, sir?
Yeah, it was extensive discussion on neuromuscular monitoring. And I think, she has covered almost all the aspects. And therefore, there's not very many questions. But at least, there are something like, when you are giving muscle relaxant, non-depolarizing, there are many factors which affects like hypothermia, electrolyte imbalance. So many things are there. They should also be, part of this coverage, because simply a simple muscle relaxant with the normal things, that is okay. But we should deviate from this to other aspects also, where all these things counts. So I think otherwise it was very good discussion. And because of the technical snag, we could not continue the intestinal obstruction. So I think everything's good. And I congratulate both the speakers. They tried well. And there was good discussion also. So next time we can discuss intestinal obstruction in another class that we can take it. So I think we should conclude the session, Dr. Madhuri.
Yes, sir. And we thank Jayadike ma'am and Dr. Sandeep and team for taking up the class and having a good discussion on the topic. Thank you, ma'am.
Thank you so much, ma'am.
Thank you, madam.
Thank you, ma'am. Thank you, sir.
Mute karna, mute
Dr.
karna, mute
Sandeep.
na maza.
And thank you both the presenters. Thank you everyone and good night.
Thank you so much, sir. Thank you so much.
Long live
Thank
ISA.
you, ma'am. Thank you, sir.
Thank you so much.